we have some time for questions. I wonder if I could first start out. Dr. Critchley, so the idea of this association of diabetes and increased susceptibility to TB or worsening TB disease. We know that sustained hyperglycemia has a negative impact on certain elements of the immune system, right? We know certain leukocytes are inhibited. I mean, do you have any insights? I mean, because TB in general is a disease of T cells, right?
Yeah.
I mean, so T cell function, and so we know that elevated hemoglobin A1Cs typically are a marker for sustained elevations in glucose over time.
Yep.
Any speculations on that and how best to look at that, or have people looked at that?
I'm ideally I will be on the hot phone to the immunologists and the TB Tandem Consortium as I answer that question.
Right.
But yes, of course, diabetes is a state of relative immune impairment. It is associated with increased risks of infection. There is a lot of interest in terms of looking at the immune system responses. What we have been doing as part of the Tandem Consortium, the immunologists actually have looked at the omics and have looked at gene expression, and they have found different signatures for people with TB and diabetes compared to those with TB alone. And one thing they found that I think they were not expecting to find was that the signatures were also different for people with impaired HbA1c or blood glucose. So for levels that were above normal but below, and sometimes well below the diagnostic cutoffs for diabetes itself. That work is actually in press at the moment. So yes, there have been people looking at that. The other interest there is and a lot of talk about, is in host-directed therapies using statins or metformin to see whether they actually have any benefits in terms of reducing TB risk or improving TB treatment outcomes. As yet, there is no randomized evidence. There are some animal studies, there are some observational studies. I have looked at the observational studies myself in terms of metformin. I'm quite concerned about drawing conclusions from them because I think that the potential for selection bias is just too immense in the sense that metformin is the first-line drug treatment for TB almost everywhere in the world. So people not taking metformin are different in some way, whether that's poverty, access to insurance, socioeconomic, or possibly they have a more severe course of diabetes, so they're put on insulin. Maybe they even have type 1 really, but they're called type 2. So I'm very concerned about drawing any conclusions from that observational research. And it's a question where we really need trial evidence, although obviously the ethics and pragmatics of doing that trial make it difficult.
Yep.
Yeah.
Okay, thanks. And sort of related, Christoph, so I really liked your mouse data, and we do know clearly that hyperglycemia impairs neutrophil function. And so when you were able to sort of restore some of the barrier effect, how do you control still for that impaired leukocyte function where the hyperglycemia is still present?
Yeah, that's interesting. I think if you look at the details of those slides that I showed, the restoration by preventing epithelial dysfunction is not complete.
Right.
So I think some of these residual problems that you might have are basically caused by impaired immune function.
Yep.
And we've specifically looked at neutrophils in this study, and we saw that there are definitely differences to be observed between both conditions.
Good.
So I think it's a combination of both immune and non-immune functions that lead to this phenotype.
Great, thanks. Okay, I'll open the floor. I think we've got some roving microphones around as well. Oh, good, lots of questions. Go ahead.
Hi, this is Gene Bookman from Harvard Medical School. I had a question about the work on TB and diabetes. How much are studies collecting socioeconomic information about patients where I think in some ways, at least say in India, there are usually sort of reverse gradients with diabetes and socioeconomic status. And it'd be interesting if the story with TB is more complicated or if it follows kind of what you might expect. And I'm just curious if you're thinking about that and doing your work collecting that kind of data.
That's a very good question, and most of the studies that I've shown you are essentially clinical data. They're registries from some kind of hospital or national TB database. So they very rarely actually collect any socioeconomic data at all. As part of the study that I was involved in, that's the Tandem study, that recruited about 2,000 patients across 4 continents in Peru, Indonesia, South Africa and Romania. We did collect socioeconomic data in quite a lot of detail there, and as you'd expect, TB is a disease of poverty. So in Bandung in Indonesia, you could theoretically have just asked people whether they had a bank account or not, and that was actually almost as good a predictor as any microbiological testing for TB. The situation, as you're suggesting, with diabetes is relatively more complex, but diabetes is becoming common amongst all socioeconomic gradients. And certainly with the data we've looked at so far, it is beginning to reverse and to perhaps become more common in low to middle socioeconomic groups in the populations that we were looking at. But that's a very interesting question. Yeah.
Okay. Next microphone. Yep.
So my question sits bang in between you both. So I'd love to hear your responses. So thanks for the presentations. I found really fascinating, Christophe, the last slide on HbA1c as being kind of a strong correlation with the microbial signal. I wondered what your reflection on why that would be compared to, say, glucose. And part of the reason I'm asking is because some of the data we're finding, and Julie, I'd love to hear your experience on this, but some of the data we found in the TB diabetes is that when we look at the associations, they come through TB diabetes very strongly, particularly in the context of HIV, with HbA1c and less with fasting or oral glucose tolerance, both at the beginning of treatment and a few months later after the intensive phase. So I'm wondering what the potential, early days I know, what the potential implication is for thinking about the screening and management and potential impact on the clinical outcome looking at HbA1c, because we've struggled with this, why HbA1c and not the fasting. So
To go first?
Yeah, so I think this is very important. And to be honest, we didn't expect to see both factors uncoupled. We didn't expect to see a signal for HbA1c, but not for glucose itself. And I think what it tells us is that what we're looking at here really is long-term glycemic control and not postprandial glucose responses. In our study, these were all healthy individuals. There were no diabetics. And nonetheless, we see even within a healthy cohort, admittedly a small cohort, but now we're expanding the numbers, and still we see within healthy HbA1c ranges, we see a correlation with microbial molecule abundance in the systemic circulation, indicative of barrier dysfunction. What it means for treatment, I think, is that basically the approaches we currently have for treating long-term glycemic control, like metformin and others, might be more applicable than the ones we have for short-term glycemic control. Of course, we haven't tried any experimental interventions at this stage because we need to increase the cohort size to be more assertive in the conclusions that we have. But I think teleologically, it's very interesting to make this distinction between short-term postprandial responses and long-term glycemic control, especially considering the biology behind the differential regulation.
You know, it's an interesting question, Tolu. I'm not sure I can answer it very directly. Certainly with the data we had on Tandem, most of the people with diabetes we identified, 70 to 80%, were actually already diagnosed. So we didn't identify a huge number with newly diagnosed diabetes. In that study, we also did blood glucose testing as well as HbA1c, and the results were similar. Whether we used blood glucose or HbA1c in terms of the screening accuracy, for example. So, but as you say, I'm aware that there is data from Africa that has suggested that there are very different associations with different markers of diabetes, sometimes finding very strong associations with HbA1c and not with blood glucose. And I think what I would speculate is there might be two populations. Okay, so there are people with TB who really do not have, who really have undiagnosed diabetes, what we might say is true diabetes, for want of a better word, and they can be picked up with any test, HbA1c, blood glucose, their levels are often quite high, well above the cut points. But there also seem to be another group, and I don't know how large that is in different populations, that may be for whom the HbA1c is some kind of marker of TB severity rather than of true diabetes, and it's correlated with a poor outcome because it's a marker of TB severity. And I don't know if it do, but some of my colleagues, the immunologists, are looking at differences in gene expression. So perhaps in the future that could be a way of understanding it biologically. I don't think that's going to be practical in clinics in South Africa, though, is it? Yeah.
Okay. One and then two. Go ahead.
Thank you so much for such an interesting presentations. So I have two short questions. So one has to do with, is there any special association with non-pulmonary tuberculosis and diabetes, or most of what has been done has to do with pulmonary tuberculosis? And then the second point has to do with practicalities of a screening in real world, okay? So nobody has talked about, I mean, how difficult hemoglobin A1C is for our countries. I come from Peru, so I have seen that, and we have discussed previously about screening, okay? And the thing is that we don't have any lab that can give you a reliable hemoglobin A1C. And to ask a patient with tuberculosis to come fasting, over the fact that he has to come every day almost to receive the direct observed therapy is really complicated. So I don't know how far we are in that sense of thinking about point of care, a point of care test that could help us with that. And just one more issue, which was also an interesting discussion when we were talking about starting a screening for patients with tuberculosis, is the fact that most of our TB patients receive what we call the food basket. So, okay, so in the food basket, unfortunately, I mean, anything that is for people that has low resources with tuberculosis, mainly has lots of carbohydrates. So the discussion of most of the people at the ministry was like, hey, and what if we diagnose diabetes? What are we going to give them in the food basket, which will become very expensive? And I mean, it may sound funny, but that's reality. So we're talking about science, but we have to talk also about what are we going to do in the real world.
Should I answer the easy question first? Yeah. Most of the studies have really only looked at pulmonary TB and diabetes, so that's where there's the strongest evidence for an association. But just because extrapulmonary TB is more rare, less often diagnosed, I don't think there is any strong evidence to suggest there is or isn't any association there. We just don't know. Your comments are very interesting. I think from a practical point of view, you'd always say treat TB first. So maybe don't worry about the food basket, because if you have a patient who presents with TB and diabetes, the first priority is to treat TB. Otherwise, it's potentially a life-threatening infection, or you may be potentially promoting drug resistance. So I think that comes back to my point. Point-of-care tests, can they be used in TB clinics? Well, we don't have a lot of evidence for that, but capillary blood glucose testing is relatively cheap, I guess. So if you were going to, that might be the obvious starting place. But I think really it comes back to the comment I was trying to make in my conclusions, is that if we're thinking about improving health rather than just focusing on disease outcomes, then what you really want to do is to make sure there's continuity of care for people who are identified with or suspected to have diabetes during TB treatment, in terms of accessibility to diabetes care and diabetes services, and having the understanding and resources to actually manage diabetes better, because for the long-term health outcomes, that's what might be important for those people once their TB has been hopefully successfully cured.
Over here, microphone.
Thank you. Marcos Espinal-Pajo. I think Patricia Garcia just touched on the same issue, but Julia, I just want to, I'm going back to the issue of simplicity. And you hit the nail. Let's strengthen health services. Let's make sure they offer everything at the first level of care. And those who cannot be treated at the first level goes to the second level of care. As long as people have in the first level of care, in the middle of nowhere, in a health post, commodities and diagnostics, I think that's the way to go, because they will feel compelled to go back there or in the community. I have seen so many initiatives to fail because they are not feasible. And we wanted to make it feasible for the entire population. Latin America is a middle-income region. Africa is a low-income region. Well, guess what? Only 6 countries in Latin America are investing in health. The minimum that WHO is calling 6% of GDP, because it's not attractive. And I'm glad you put Tony Harris there, because Tony Harris probably is the best TB researcher the world has produced in terms of simplicity. I learned a lot with Tony Harris when I was working in TB. And every time he was coming from Malawi, he was telling me, Marcus, simple things that can be done. And I wanted to ask you, have you seen any good experience, because this is about synergies, on synergizing some of these simple things like glucose testing and availability of treatment on TB and diabetes on your research? Because Tony's been asking for that for the last 5-6 years after WHO and IOTL, they came with this guideline that you mentioned that. So I wanted to ask you, have you seen any good, because I think one of the recommendations here is that, yes, we can find synergies, but also you need to strengthen health system to make sure everyone have access. Not only few, because it's important if we can replicate research. At the end of the day, that's what policymakers want. So have you seen any good experiences on practices that could be potentially replicated province-wide, statewide, countrywide? Thank you.
Yeah, I think I would completely agree with you. I mean, we found the synergy, but what is the appropriate health system response? How much have health systems reorientated? How much should they be orientated? Is there any real health benefit for patients if they do? And those are the questions that haven't been answered. Now, there have been attempts to actually integrate screening in places like the Pacific and India. In terms of the longer-term outcomes, I think they're too recent to say at the moment. So you can add, blood glucose testing into a form for TB patients, but I don't think we have the longitudinal data to actually tell us what the patient experience is and what the outcomes are at the moment. So answering your question is very, very difficult. I guess there's a twofold answer. So some first steps around integration have been made, probably in a limited number of places, not in Latin America, to the best of my knowledge. But in terms of actually evaluating how much that improves the experience for the individual, I don't think there is an answer for you as yet, but it's clearly the point that needs to be made.
Okay, other questions? Sir, get the microphone over to you.
Thank you. Masama Sharala from South Africa. I'm interested in the comment that you made about having studied TB patients and testing them for diabetes, and the limited information or data on diabetes patients with diabetes, trying to understand TB amongst those. I'd like you to expand on that, and even if you have to speculate, that's fine. And the reason I'm asking is because, as you said, TB, it's more immediately life-threatening, but it comes and goes, but diabetes is long-term. And I was just trying to think in my mind, how do we actually try to integrate care for patients? That's a challenge in my mind. And I think that if it's difficult to study the epidemiological patterns for patients with diabetes with respect to TB, chances are very high that it'll be difficult for us to think about how to organize care for them. So I was just wondering if you have any thoughts on that. Thank you.
From an epidemiological point of view, I'm not sure it is so difficult to study. The evidence that we have just tends to come from registries and cross-sectional data. So if funders were prepared to put money into longitudinal studies, then it wouldn't be particularly difficult to study that from an epidemiological point of view, notwithstanding, losses to follow-up, movement, migration, and other issues in any longitudinal study. In terms of the question about reorganising health systems, I think that is more difficult to actually answer. But I would say go away and have a look, download the recent sets of guidelines that are available from the World Diabetes Foundation and IUA-LTD, because they do try to make a kind of a very simple framework about what to do if you are in a primary care clinic, in a rural setting, and you've got a patient that you think might have diabetes. What do you actually do? So they talk about the tests that you can do. They talk about the results that might mean you should try and contact diabetes services, for example. I'm not sure if that was your question, though, entirely. I'm not sure if I understood.
Yeah, no, it's partly the issue, but I think you're raising some other things that I think are important in terms of funding and interest and prioritization. I think that
yes.
I think that there are other issues that are sort of starting to emerge from what you're saying that are sort of kicking in my mind.
Well, I think the other lack is the kind of cost effectiveness angle. There haven't been any perhaps economic evaluations of the kind of reintegration or reorganisation of health services that might be needed to address these joint epidemics. I mean, one of the reasons why I talked about the 1950s clinics in the UK is because there has actually been a whole historical example of TB and diabetes clinics that were apparently successful in reducing the mortality rate from those two joint conditions. So there's a kind of historical example that is quite interesting, but we haven't had the economic evaluation. So, I mean, what do we actually need to do in primary care services? So I think, if I'm right, only about half of TB clinics would have any access to blood glucose testing anyway. So what actually needs to be done to actually try and roll that out? Obviously, you're not going to build new labs everywhere. That would be hugely expensive. So you're talking about probably getting point-of-care tests in place and getting those used and looking at the cost-effectiveness of that. But for me, that question about the cost-effectiveness comes down to having the long-term follow-up of these patients, because if you identify someone who has undiagnosed diabetes during TB care, you may or may not be really helping that person, okay? I mean, if they can later on access high-quality diabetes services, then the benefit for their long-term health can be positive, because we know from classical trials that good glycemic control does reduce the risk of microvascular complications, retinopathy, neuropathy. You're less likely to end up having an amputation in the future. But there are many big ifs along that journey, and I don't think we can look at the cost effectiveness until we actually know what the kind of patient journeys is, or the outcomes are. So some of my colleagues have hypothesized that you know, in the study that we looked at in tandem, a lot of the people that we picked up were not actually undiagnosed. They knew they had diabetes, but they didn't have any care. So it's actually also trying to find the reasons they've dropped out of care. And there was a mixture of reasons. Some are economic, some were, you know, I'm feeling fine, not appreciating why it might be important. So optimistically, TB services could provide a way for some patients to reintegrate with care, but only if the services are there to kind of pick them up at the end of TB treatment. And that is where the synergy most concerns me, to be honest. I mean, I can pick up and evaluate the epidemiological evidence, but the carrying on into the future and what happens to those patients has been is really a big gap.
Okay. Well, I think with that, we'll end the questions. There'll be opportunities later on at the reception if there are more questions. But thanks very much to the speakers.